Okay, great. So we have got lots of questions. We probably won't get through all of them, but we will do our breath. And it's going to be a little odd because I might be asking myself some questions, but let's see. Okay, so Robyn, first question for you. Let's see, you talked about a little bit about this. What could be the reasons for O2 saturation levels not going higher than 95 and often remaining in the low 90s on a good day?
That is a really good question, very loaded. Lots of explanations can go into that. That also include glial cells and astrocytes and other dysfunctions, something that on our Stripe Solutions platform, Dr. Patty Stott is actually putting a lot more information out there currently in our latest month and upcoming months on releases. So I can't speak quite as much to that as I would like to. I think that's a better question for myofunctional therapists at this point.
Okay, thank you. Dr. Rozenberg, can respiratory health be normal during the daytime but problematic at night, making it hard to get good quality sleep?
Yeah, it's a good question. Certainly, you can get nocturnal symptoms, so at nighttime, increased symptoms. So if that's the case, you need to kind of explore with your partner or others that may be around whether there are any symptoms of sleep apnea, snoring. Do you feel fatigued when you wake up first thing in the morning, headaches, and may require sleep study? The other thing to think about is a lot of airway symptoms. So asthma, COPD, specifically asthma, can become worse at nighttime, and you can get some diurnal variation or hormonal changes as well. So it also depends on the type of symptoms you're experiencing. Are you experiencing wheeziness, etc., or is it more aspiration-like symptoms? I have a number of patients in my practice that need to sleep at a 20 or 30 degree angle because they're aspirating. And so there's certainly a number of symptoms that need to be considered, including the ear, nose, and throat concerns, such as postnasal drip. Those are some considerations. You really need to think about the stomach, the ear, nose, and throat issues, and then are there any lung issues that need to be addressed with sleep apnea?
Great, thank you. Robyn, I'm doing breath work through a pelvic floor PT, but it seems to cause constant irritation, trap pain, and increases shoulder and rib subluxations, even though this is gentle breath work using all of the breathing zones. It makes it difficult to assess whether to keep pushing through in the hopes of getting to a better place, or is this something that just takes a long time to work on?
Okay. Also a really good question. When I was talking earlier about how the baseline level for where the hypermobile population kind of starts with a lot of these exercises, it's very similar to traditional PT where it just seems to be like so much lower than the traditional starting point and baseline that it honestly might be a case of that you're not starting easy enough. You might not be quite at a low enough level to meet your body where it is currently at this point. We do need overload and adaptation. That's how we grow and respond physiologically. So what I would encourage there is, it sounds like there's some, I don't want to jump in or assume anything, but I'm hearing some signs of like compression pressure mismanagement. So with the inhale, I would say working really on relaxing as much as possible during the inhale is a pretty big part of it, especially with the pelvic floor. And one of the papers that I don't remember if I referenced it or not, but there's a great one about can women actively relax their pelvic floor on an inhale. And if you give them the cue, relax your bottom, that seems to do the trick for most people. So it's just one little trick you could try, but I would say it's probably keep going, but it may need to be something where you're reevaluating if there are signs, symptoms of dysautonomia and other vascular compression mismanagement that might be occurring. And then I would also encourage getting rechecked for rib cage abnormalities, for vascular compression problems, neurological impingement, upper cranial cervical instability, and kind of the list goes on too if you're not seeing progress, especially after 2 months in continuous modification.
Yeah, thank you. Dr. Rozenberg, could you talk more about EDS-related breathlessness? Why can someone have normal oxygen levels but still feel breathless?
Yeah, so that's a good question. I mean, oftentimes the oxygen saturation is dependent on the actual parenchymal or lung involvement. So as you saw, for instance, when we had the vascular EDS picture, if there's some involvement of inflammation or blood or water in the lungs, then that may drop your oxygen levels. Or if there's really bad asthma and those airways are tight, that could drop the saturation. However, if that's not the case, and you've got more of a restrictive phenomenon due to muscle, chest wall problems, the perception of shortness of breath, then that shouldn't necessarily affect your oxygen saturation. And in fact, most of the time, oxygen saturation levels are often normal. So if there is a lower than 90% or even in the low 90s, there may be something else going on that needs to be explored with your healthcare provider.
Okay.
Yeah.
Thank you. I'm going to ask myself a question. Someone's put a question in for me about diaphragmatic breathing, and they're struggling to do it when they're bloated and working on stability. It feels like I breathe in two places, upper abdomen and lower abdomen, and they don't work together. Is that normal in EDS patients? Yes, I can totally relate to that, yes. So diaphragmatic breathing is the gold standard of breathing that we want to sort of promote. However, if you are someone with a very tight thorax, and a lot of us have that, and I see that every day with my patients, jumping straight in to do diaphragmatic breathing is going to feel like that because you're literally pushing the air down when the thorax hasn't had a chance to expand and open. So it is going to feel like you're kind of cutting yourself in half. So before we get into the diaphragmatic breathing, we've got to do a bit of softening and letting go of some of that habitual tension in the thorax area. That way you can start to expand that tensegrity that we were talking about to allow the breath to actually get down into that area. But yeah, we don't want to be, as Robyn was saying, pushing the belly out. That's just another tensional pattern that we want to get rid of. So we want to work towards diaphragmatic breathing, but try starting a little bit further up and softening this area first, okay? Okay, Robyn, let me see. There's so many questions here. Sorry, guys, I've got to go through them. How does breathing dysfunction connect to severe scoliosis?
Oh gosh, so all of your ribs attach like bucket handles from the front to the back, from the sternum to the spine. So if you have a displacement where your spine is curved, love my EDS fingers here. If you have that displacement where the spine is curved, then the facets and the length tension relationships between the spinal support muscles on both sides are greatly altered. And then depending on if you have, let's say, for example, one QL, quadratus lumbar muscle in the back that becomes hypertonic in response to curvature in the spine for stabilization, then that can directly affect how the diaphragm on that side in the back is able to contract and pull off of the zone of apposition, which is kind of this overlap place where the diaphragm and the rib cage are in contact with each other, and when you inhale, that zone of apposition decreases and then increases again. So when you have scoliosis, you can kind of make an imbalance one side to the other with how that diaphragm contracts, how the intercostals and then how the secondary muscle support are able to promote that inhalation exhalation. So with my clients that do have the scoliosis, in addition to any sort of rib cage dysfunction or diaphragm dysfunction, we work very specifically on balancing and trying to derotate if there's spiral line rotation or myofascial train binding that is contributed from that. So it definitely, absolutely, it can, and then it's kind of addressing symptomatically and correcting for the postural. Also, fascial counterstrain. I just want to put that word out there. If you haven't heard of it, look it up. That is also massively helpful towards alleviating some of these fascial tensions that can help to promote better diaphragm breathing patterns.
Great, thank you. So Dr. Rozenberg, there's two questions here, but they're linked, so I'm going to give them both to you. Is there a relationship between asthma and EDS? And second question, does adult onset asthma truly exist, or is it just a catch-all term?
Yeah, no, those are good questions. I'll tackle the first one and then get into it. So certainly there has been a relationship that's been described in literature between EDS and hypermobility spectrum disorder, and multiple terms have been obviously evolved since the nomenclature has changed since 2017. But the bottom line is there is a link between mast cell activation, atopy, asthma, and so we do see a higher proportion of individuals with EDS and HSD who are experiencing respiratory symptoms and asthma. It's a bit tough to quantify on a population level, but something that requires further exploration. In terms of adult onset asthma, certainly, asthma on a general population outside of EDS, if you think about it, there's the childhood and teenage onset, and then you may hear the term someone outgrows it, and certainly you can develop adult onset in your later part, so in your 40s, 50s, 60s. So that is also certainly a possibility, and we see that clinically as well, and need to consider that and undergo appropriate testing, including spirometry and methacholine challenge to make that diagnosis.
Great, thank you. So I've got a question here. It was assigned to me, but let's see, either of you. I have thoracic outlet syndrome and tend to either hold my breath or not breathe deeply. What strategies can be used to help my breathing? I'll give my views, and then if you've got some inputs. So yeah, I have a lot of clients who have thoracic outlet syndrome. And again, creating that space and that softening in the rib cage can be really, really helpful. And doing exercises that really help open up that space. Again, working on that breathing pattern. Again, it's painful, right? So we might change how we breathe because we're worried about the pain or what might happen. So very gentle approach to the breath, so that we're not going into that pain zone and getting fearful about that. But plenty of movements and exercise you can do with the breath to help with that condition. But really, as I say, starting to feel a little bit safer in your breathing can be really, really helpful. Robyn, did you have anything to add?
Absolutely. Just to go back to the rib cage stuff for a second, I would encourage you to take, again, a look up here. Sorry, I'm like hitting my mic. Especially in the top ribs and the sternum, if there's any sort of carinatum, and that's where you have the bowing out of any of the rib cage structures, that can increase a lot of pressure in this space where you have your plexus is sitting. No, words I say all the time, and they're just out the window now. So yes, your brachial plexus, you have 3 nerves that kind of come through here. You also have a lot of vasculature. And if that is either compressed from bowing out, or if you have the opposite, where you have the drop angle and your sternum's pushed in, or you have rib flare, and you're in this posture, you have a very similar effect from over tight pec minors and upper pec muscles, and then all the interplay up here, again, can put a lot of compression on that. So if you find that your hands are going numb or tingling, or if you've got certain specific spots, it kind of dictates which of those nerves are super irritated. There could also be stuff coming out of the nerve roots in the neck. So I would encourage you, if you're doing the exercises but you're getting the exacerbated symptoms, then again, what Jeannie was saying, it just might not have had enough time to give and learn and open up. So we got to go really, really, really low and slow with progression with the hypermobile population. You can still do a 10% progression of load, but when you're talking about like a tiny inhale, like working with 500 millimeters, which is not a lot, then it takes a lot longer to get up to kind of a baseline typical functioning place. Yeah, that helps.
Yeah, and I'll just add, obviously exercise and postural strategies are quite important. So, and I often undertake some form of imaging, whether it's ultrasound-based or CT-based, just to make sure that plexus isn't compromised and may require surgical intervention. Yep. As you heard from previous colleagues, surgery should be a secondary resort, and really trying positional. And I haven't had to refer someone for surgery. Well, I've referred for thoracic opinion, but no one that I've had go for surgery at this point yet.
Okay, so I'm going to give the last question to you, Dr. Rozenberg, if that's okay. Can EDS increase the risk of pneumonia? I have EDS and asthma and contract pneumonia multiple times a year, requiring antibiotics and steroid treatments.
So it's a good question. I don't know the exact direct link between pneumonia and EDS, but certainly there are certain risk factors that may predispose someone to increased pneumonia. If you kind of think about an individual even outside of EDS, if someone's getting recurrent pneumonias, you want to think about whether this person's aspirating perhaps. Is there another process like a common variable immune deficiency? Is there some common pathogens that are constantly growing in the airway that are not necessarily being covered appropriately, like Staph aureus or maybe gram-negatives, if there are recurrent infections that are being treated on a monthly basis? So certainly urge to get some sputum so you have an idea of what flora you're dealing with, including atypical mycobacterium, which is a type of bacteria that requires chronic therapy. But if you're dealing with a bacterial pneumonia that's consolidative, certainly you need to look into that a little bit further with your provider and make sure you get appropriate imaging beyond X-ray, CTs. It's resolving appropriately, and there's quite a broad differential for recurrent pneumonias. There's inflammatory conditions as well, so you need to kind of discuss that with your providers.
Great. Thank you so much. Those are all the questions we have time for. I'd like to thank our speakers, Robyn Fog and Dr. Rozenberg, for their time. And thank you all for staying. I know it's been a long day, but I hope you've enjoyed it. So thank you. And I think Lara's probably got is coming on to talk to us.
Happy birthday.
Thank you.